Hello, and welcome to NANNcast. I'm Jill, your host, bringing you another episode on hot topics in neonatology. As the opioid crisis continues, mothers are becoming increasingly aware of the risks of using prescription and non-prescription opioids during pregnancy. There seems to be a trend among pregnant women towards seeking alternatives to opioid painkillers, such as heroin and oxycodone. Kratom and CBD are two such substances that are on the rise and has potential to be a source of withdrawal for newborns. Many obstetricians, neonatologists, and nurses are unaware of these new supplements and how many mothers are using it. We as NICU nurses need to be familiarized with the potential effects of these substances to our patients. And if we aren't aware of these substances, how can we adequately diagnose and treat our babies? Do they show signs of withdrawal? How do we treat them? One nurse, Maureen Shogan, is going to shed some light on newer prenatal drugs and how they are impacting the newborn. Maureen is currently the clinical director for a National Institute on Drug Abuse Phase 2 $1 million project on developing neonatal abstinence curriculum for mobile devices. An app for NAS scoring is included in the project. She is an active member of the Washington State Perinatal Collaborative, as well as the Washington State Pregnant and Parenting Opioid Work Group. It's my pleasure to welcome Maureen to the podcast. Let's get right into it. Hi, Maureen. Thank you for joining us today. I know that in my clinical experience, I haven't been exposed to Kratom and moms that are taking it. Could you let us know what is Kratom and why do people use it?
Sure. Kratom is derived from a plant that's grown in Southeast Asia. And it is basically the active ingredient is metabolite 7-hydroxymitragynine. And the reason that people take it, the one that I found in my clinical practice most often, is that women are trying to wean themselves from opioids. And so this is one of those particular substances that is very interesting based on the dose. If you take it in a lower dose, like 1 to 5 grams, it's used as a stimulant, but higher doses, anywhere from 6 to 60 grams, is what individuals would try and use for their opioid withdrawal. And as a result, you still get the same kinds of effects. It's not an opioid. So Kratom is not an opioid, but it acts on the opioid receptors. So you will get some of the opioid-like types of side effects, such as constipation or itching. It comes in a powdered form. The leaves are pretty large, just kind of open up the palm of your hand, and that would be about the size of the palm or the size of one of the leaves. It's ground up, and sometimes it's taken in the form of a tea. Other times it's ground up into a very, very fine powder. To me, it looks like a yellowish, very light green powder, and it's placed in capsules. And each one of the capsules is approximately 0.5 grams. So if someone were taking 60 grams per day, that would be taking 120 capsules per day. And this is one way that some individuals, instead of going to medication-assisted treatment program or going through counseling, will buy at a convenience store. They can buy it online. I have signs around town here. I live very close to a Veterans Administration hospital, and there's a big sign that says Kratom, CBD, and vape juice available. So I see it quite a bit here. I paid more attention to it since an article came out in Pediatrics a couple of years ago related to women taking either in a tea form or capsules in which their babies went through withdrawal, because the way it does attach to the opioid receptor sites. Individuals can have tremors, sometimes anorexia, sometimes psychosis, and there have been reports of overdoses. So that sometimes Kratom is found on toxicology along with heroin or oxycodone, or when individuals do overdose. There's not very many cases in which Kratom is the sole substance which is found. The other thing is Kratom is not found on a regular urine toxicology. Like if someone came into the emergency department and you get a screen, and it's usually 5 classes of drug, kratom's not there. But I do know that in our medication-assisted treatment program here in Spokane, it is a drug that is assessed for when women come in for their UAs. So, but you have to really request it and ask for it. So a couple of months ago, it really hit home for me, in which I have a very good friend, and she told me she was going to be with another friend of hers, in which this friend's child was found unresponsive on the bathroom floor. And so the mother found the child and had to give CPR to her 40-year-old child. And they were admitted to the ICU, intubated, on a ventilator for 4 days. And the adult child had vomited and aspirated a greenish substance. His history was multiple joint surgery, so he'd been on opioids for his pain. But his mom, after coming home from the hospital that first day, found 2 bags of kratom capsules, 160 in each bag, in the child's home. Now this person is a professional, and was very close, as far as in the rung of very close to the CEO type of status. So after 5 days, the individual was off the ventilator, took 3 attempts, and then was placed on Subutex or buprenorphine. So that would be exactly what we would do if the person had been taking heroin or oxycodone. But still unclear whether that individual was taking a combination of kratom and the pain relievers. So the outcomes for newborns, interestingly enough, is there were case studies that were published in pediatrics and also in obstetrics and gynecology in 2018. And that's when I really first heard about it, or really paid attention about it. We weren't asking our moms about it, but when we talked to the staff in our medication-assisted treatment programs, or what we used to call the methadone programs, they would say, oh, yes, we see several people who will come in. I live on the eastern side of Washington State. I'm only about 20 minutes from Idaho. But I do know also in the Seattle area, which is about a 5-hour drive for me on the west side of the state, that they also are seeing that as well. So it's a drug in which a couple of states have made it illegal. It is considered legal. As far as the U.S. goes, it's not considered a Schedule I drug, but there was movement about 2019 to take it off the market and make it a Schedule I drug. But states such as Wisconsin and Indiana and Alabama, Arkansas, and Vermont, it's illegal. And there are certain cities around the United States in which those municipalities have made it illegal, such as San Diego and Saratoga, Florida, and then a couple of cities, Monument and Parker in Colorado. So as far as currently, it's very legal for individuals to buy. I think one of the things that we get very concerned about is kratom use in pregnancy, and how does that affect that? How does that affect the fetus, or how does that affect the newborn? And a case study by Smith and OBGYN in 2018, the mom had ingested it as a tea. So she had had it daily as a tea, and she used it for opioid withdrawal. She used it for 7 months prior to verifying that she was pregnant at 16 weeks. She then discontinued the kratom, but she restarted it when her symptoms of going through withdrawal reappeared. So on a UA tox, there were 980 nanograms per deciliter, and the reference is less than 1. So she had significant amounts there. She went into a program and placed on 8 milligrams, or was stabilized on 8 milligrams of buprenorphine. And then she had severe depression. She asked to remain on the buprenorphine, but maintained about 2 milligrams. So her baby was born at 39 weeks, no evidence of neonatal abstinence syndrome or neonatal opioid withdrawal, which would even though it's not an opioid, the symptoms would very much be the same. Baby was able to room in, breastfeed, and did go home with the mom at day 3. So that was a pretty good outcome. In another case, there was a mom that presented to the emergency department at 19 weeks, and she was concerned. The reason she had brought herself to the emergency department was for withdrawal secondary to smoking kratom. So she smoked it. So she would have taken the leaves and rolled it and smoked it. But she had a history of IV heroin use. Her last use was 6 months prior. She had bipolar disorder. And this is, moms want to do the best for their babies. They really do. And this particular mom had been abstinent for 10 to 12 hours. So she had not taken the kratom for 10 to 12 hours, going through withdrawal. The reason she discontinued, because she wanted to decrease the risk for her baby. So she was really, really thinking about her baby, but she was in withdrawal. And that's pretty scary when you're pregnant to go through withdrawal, and when people may have told you that you may not. So she then was hospitalized, placed on buprenorphine, and discharged on day 3. She switched to e-cigarettes. She had been a smoker, and she was induced at 39 weeks. Mom and baby were discharged at day 2. However, the baby was readmitted on day of life 4 and treated with morphine. So the baby was probably not withdrawing from kratom, but was withdrawing from the buprenorphine. So the baby was able to wean off and discharged on hospital day 12. This is another case study by Eldridge in Pediatrics in 2018. This particular mom drank kratom tea. She last used oxycodone 2 years ago before her delivery. She had a negative UA on admit. The baby was small for gestational age. At 33 hours, the baby had symptoms of neonatal opioid withdrawal, of sneezing, jitteriness, excessive suck, some facial excoriation. So the baby was definitely going through withdrawal, and the Finnegan score had gone up to 14 before they started the MS. Interesting on this baby, I'm not exactly sure why, but the baby went into some sinus bradycardia. They rapidly weaned, so the baby was totally off the morphine by day 3. The scores rebounded back up between 11 and 13, and then they started clonidine. Clonidine was discontinued at day 5, and the mom and the baby were able to go home together day 6. The dad disclosed the mom's use throughout the pregnancy, so she used it to help her sleep and also for withdrawal symptoms. So those were the 2 reasons that particular mom used her kratom. So we don't know a whole lot about kratom use. We've got these 3 case studies. We do know that moms will use kratom for their on their own to try and go through their own opioid withdrawal without going into treatment, without seeing a healthcare professional. I did have a child and family services worker ask me in a workshop once. She said, I've got clients who use kratom. Would you recommend that they just go ahead and go get kratom? And I said no, because one of the things as far as medication-assisted treatment is the counseling that goes with it, to look for the underlying, as far as substance use disorder is there's so multifaceted. So no, I would not say, hey, go just right down here to your friendly little gasoline grocery store and go ahead and pick some up. And this is the dose I'd start out. I would never, ever do that. The other thing is, I did go buy some. I went into a place that is every time I come home from work, was right on the way, and I needed it for a photograph for one of my lectures. So I went in and got it. It's absolute. All I know is I bought some gold, which is, there are so many different components. I had to go online and read about it, because there's red vein, green vein, yellow vein, and online you'll get all kinds of information. They're public websites. They're not professional websites by any means. But the interesting thing is the capsules were not marked, and neither was the little Ziploc bag. So there were no identification of contents, no identification of how many milligrams per, how many grams, or per how many capsule. So, and again, you really never know what some of these substances are going to be mixed with as well. It's a throw of the dice when you're dealing with these kinds of things. So no, I'd never recommend it, but because it's so easily accessible, and in my part of Eastern Washington, the signs are, and they're big signs, they're huge posters, bulk kratom available, one of the places you go to. So anyway.
So do you think because kratom doesn't normally show up in a typical urine drug screen, we are seeing these moms doing it so they don't get the negative effects of, the stigma, oh, you do this or, whatever drug of choice they did, and hope that they can fly, essentially under the radar by doing the kratom. So do you think in the future it would be something that we could do as an add-on to a urine drug screen to maybe see if mom was using? I mean, is it that popular that we should be concerned about it as far as adding it to our urine drug screens? Like, I know we add fentanyl now to our typical urine drug screens. And is that the wave of the future now, you believe, with these substances?
I think one of the things that we have to do is, number one, and I'm so glad that everybody has joined this podcast to get information on this, is that we get educated so then we can talk to our moms and we can ask the questions. So, if we see that a baby has symptoms of withdrawal, the first thing I always ask about is nicotine. Do you vape? How much do you vape? Because it mimics so much. And we are asking fewer tobacco questions and more nicotine questions. And that's a key that I brought it up at our state level as well. And also asking about how much kratom do you use? And they'll say, I have no idea what you talk about. Or they'll say, oh, maybe I take, and they'll tell you milligrams, because the verbiage is like, usually 0.5 milligrams in a capsule, usually. And they would tell you how many capsules they take. And again, the stigma is not going to be there because it's not heroin. And I'm not trying to get oxycodone or hydrocodone and steal it from my grandma. But it's kratom because here's the other thing. It's natural. It's natural. It's from a plant. It's natural. Kind of like cannabis, is natural. And so it's been very interesting at our medication-assisted treatment program that it is routine on the screen. And that's not true all over the state. It was, I had gone to a meeting about 6 months ago over in Seattle, and the people from all over the state were there. So it was a good sharing time that individuals at other MAT centers then said, well, maybe we should start looking for this. I think it would be one thing that if, again, the nicotine, we think, well, no nicotine, we don't have, hypoglycemia is not an issue for the baby. It's not positive for any of the other opioids. To then ask the practitioner, can we go ahead and get a mitragynine on this mom and or on this baby? And I'm trying to think, as far as looking at umbilical cord tissue, I don't believe that any of the companies, there's one company that may start to have that on their panel, but that would be one thing to also think about as well.
Yeah, I think, when you're in nursing school and you're dealing with adult patients, they always tell you, ask what kind of herbal medications they take, because, but I don't think we automatically think that with when we're dealing with the babies, like, what did mom take, and the interactions. We know how illegal drugs interact with different kinds of psych meds these moms are on as well. So, you wonder what's kratom. If they're taking kratom, how does that interact with all of the other medications that mom's on? Her Xanax, her, Wellbutrin, and other medications that she may be prescribed.
Exactly.
Now, you were showing us those case studies and talking about how the baby seemed to be able to go home rather quickly after exposure to kratom in utero. But what kind of effects do you normally see? Like, what should the nurses be looking out for withdrawal symptoms from kratom? Is it always mimic other illicit drugs, or is it or opioids, or is it something a little bit more different?
I think that one of the things is when you look at the site of action is going to be the mu and the kappa receptor sites, which are exactly the same sites that the other opioids, heroin, methadone, and fentanyl, etc. So one of the key things that happens is when you have the stimulation of those receptor sites and also an increase in really what happens is an increase in norepinephrine. And so then the symptoms are basically going to be the same as a result of that increase in norepinephrine or changes in serotonin and changes in dopamine. So you would definitely see the jitteriness, sleeplessness, irritability, excessive suck, and excoriation from movement, excessive movement, and tremors at rest as far as all, and also as well disturbed tremors. So pretty much the same kind of thing that you would see with opioid withdrawal.
And you would treat that the same. Like you mentioned, getting buprenorphine, neonatal morphine. So it would be the same course of treatment for those clinical presentations as well. So you would score them and treat them the same as if they were exposed to a normal prescription opioid or heroin that mom was taking.
Right. I think one of the things too is to think of the comfort care, because comfort care and having the mom room in, if you've got a particular area where she can room in and it can be quiet and not a lot of visitors in the room. Comfort care, we've definitely found, has been an incredible tool in our toolkit, which can many times prevent the administration or prevent the need for opioids, administration of morphine or methadone to the newborn. So I would go non-pharmacologic care for the baby, just as we're moving towards now. And it's very interesting. It's East Coast, West Coast, where we have, it's usually how it happens, comfort care, or looking at the group in Yale, and also Boston Medical Center with Eat, Sleep, and Console. So looking at non-pharmacologic care first, and then if you did have a baby who really was unable to sleep or eat or console well, then consider having group huddle, and then considering morphine or methadone, whatever drug is used for neonatal withdrawal. But I think the major thing is looking at the mom being the medication. So having the mom and the baby together, if you've got that particular geographic ability in your units or on your mom-baby unit.
Oh, yeah. I think that would be a very good other podcast to talk about the benefits of Eat, Sleep, Console versus the traditional treatment for neonatal abstinence. But because I know I've heard many arguments on both sides. And, unfortunately, some places just can't accommodate
Right.
Eat, Sleep, Console. But I think we try to use the moms as best as possible. And so that's another discussion for another day.
Yes.
So we discussed earlier how, we really have to have a thorough discussion with mom as far as what else she's taking, if she's, in taking other kind of herbal supplements like Kratom. And we do find out that mom's taking that, for her withdrawal. What would be the next step, to get mom, in a treatment program? Like, what would we do to help mom work her way through that so she can be the best for her baby when the baby goes home?
Right. I think one of the things that has been helpful is I'm aware of other moms who've come in and they've been using Kratom, trying to get off of their particular drug of choice, whatever it was. But I think from a safety standpoint, what would be one thing that you may want to consider is to go into either a treatment or to be able to see an individual who can prescribe buprenorphine, which is very safe, and we can give lower levels. It's very consistent, because I think sometimes it's difficult to know exactly what you're getting in your Kratom, so that would be one thing that for you to be able to consider to to do that, because there's a lot of different ways that individuals are able to help and provide services, not just with the Suboxone or buprenorphine or Subutex, but in other avenues, counseling, etc.
Yeah, I know, like in the treatment program that's affiliated with the hospital that I worked at, the group therapy and their therapy is what really helps drive all of their, how their progress is in their program. So that is very important. And if they miss that, if they're trying to, self-treat themselves with Kratom. So that is really important, because the baby's only going to do as well as mom does, after they're discharged. So we have to really, look at that as a family-centered care and make sure that we're offering mom as much support as we give the baby in our NICU.
Exactly. And I think when you get into group care, because I know that through our MAT, there's groups with moms and babies together. And so it's those moms, those women understand other women, and they feel less stigma there as well. I think how we approach and non-stigmatizing is absolutely essential. And I think one of the key things is looking at it from the standpoint is this mom is really trying to do what she believes is best for her baby. And she believes that if I can switch from heroin or all the burglaries or stealing or whatever I have to do to try and get other drugs or money for the other drugs, if I can do this in a safer way. So that's also the perception that Kratom's safer, when in fact, you can overdose, especially we definitely know with other drugs on board. So we also have to look at the strengths. So we have to look at strength-based for our moms as well.
We're talking about Kratom and how we are seeing this as a new substance emerging with our pregnant moms. But we're also seeing women using other substances like CBD oil and different CBD products that are out there. They're everywhere. You can get them online. You can get them at any store that you go to. How does that differ from THC? And that's something that we're used to seeing. But, how is the CBD different?
Right. So CBD is a compound in the cannabis plant, just as THC is, but THC is the psychoactive component. CBD, very few psychoactive effects, and in order to be called CBD in the United States, you have to have a product that's less than 0.3% THC. So that's what the ground rules are, and CBD is usually made from hemp. And one of the things that happened in December of 2019 is that there was a change, federal law change, that hemp was no longer considered Schedule I. So it's much easier for farmers now to farm the hemp plant. If you drive along it, it really looks like marijuana. It's very difficult for individuals to see the difference. But CBD does come from hemp. There's no short-term memory issues, no sedation. The key thing about CBD is it's used for a lot of different things. Used as an antiemetic, used as an analgesic, used for itching for your mosquito bites. But one thing the Food and Drug Administration has very, very strongly said, you may not sell that product and stipulate that this is what you can use it for, because they will write the manufacturer a letter and say you've gone beyond the boundaries. So what the companies do is they title their particular product something like relax or sleep or energy or better living. So the other thing that's very interesting, I found a whole entire display in a huge, huge grocery store chain. And I was just pretty shocked and appalled. It was in the pharmacy department. So what does that do? It really, really legalizes that a great deal. However, the statement that came out October 20th of 2019 from the Food and Drug Administration, the FDA strongly advises against the use of cannabidiol or CBD, tetrahydrocannabinol or THC, and marijuana in any form during pregnancy or while breastfeeding. And one of the studies that came out in July of 2020 had to do with what actually was in CBD, because it's not regulated by the Food and Drug Administration. We don't know if it's safe. We don't know if it's effective. We don't know what dosage is considered safe. We don't know how it interacts with other drugs or foods. We don't know if there's dangerous interactions, other safety concerns. Not to be confused with the cereal we get with hemp seed in it. Okay, so hemp seed's okay to be in food. There's no objections as far as the FDA is concerned regarding it as a food ingredient, but they are very concerned about it as far as CBD. So cannabidiol it's against the law for it to be added into food, but you see it in gummies, you see it in everything. There's been questions: can you have a positive UA for THC if you do CBD? Well, I was one of those very naive, it says it's 0.3%. No, you wouldn't have a positive UA until I ran into a waiter and he told me, oh, I've been using CBD and I'm positive on my UA for THC. So I started looking. And one of the key things, Bond, Miller, and Bondry out of Baltimore, 84 samples, 1/4 contained the stated amount that was on the label. 1/4 had THC in it enough for impairment and intoxication, and 1/4 had less CBD than advertised. And so that was in 2017. But in 2020, July 2020, there was a report to the U.S. House Committee on Appropriations and the Senate Committee on Appropriations that came out from the FDA I think second week of July. 147 different products they tested. They tested for 11 cannabinoids. 49% contained more than 0.3%. So half contained THC more than the minimal level. One product even had 3 grams of THC in it. 102 of the products listed on the label the CBD amount that was supposed to be there. Only 45% actually contained that amount. 18% had less than 80% of the amount listed, and 37% contained at least 120% of the amount listed, because there's no FDA regulation. So Congress basically has told the FDA, you've got to go back, you've got to do more research, and we've got to have a better handle on this. So because it's so readily available, as you said, it's been normalized. And since we don't know what can happen, we don't know what the effects are during pregnancy, there would be no way I, as a healthcare professional, would say to a pregnant woman, sure, go ahead, because they believe nurses. They're the most trusted, most honest. I would never say that. I would never make that recommendation. And someone told me that they were. I'd say, I would rethink that, and I would probably cite these particular studies that were done. The other thing that's disconcerting is CBD calls to poison control centers, and they're going up exponentially. So in 2018, there were 519 calls throughout the United States. 2018. 2019, 1,529, so it tripled. And in the first 6 months of 2020, 921, which would get us a trajectory of about 1,800 calls to the poison center. So what we know about CBD in pregnancy and breastfeeding, I love this slide. It's one of my favorite slides to show. This is what we know about CBD in pregnancy, and all the rest of it's blank. We know zero. We know zero. So that's, for me, because we're growing little brains when we're pregnant. I mean, we're doing so much, and it would be just a tragedy if later on we found out down the line what these effects could be. I'm very, very conservative in this area because I've worked with moms and babies for several decades, and anything we can do to prevent any mishap from occurring, I'm all for it. So that I'm very conservative that way. So I would follow what the FDA recommends, advising against the use of CBD. The other thing, too, is the American College of OBGYN. They recommend marijuana and CBD are not recommended. So citing professional organizations is one thing that's very important instead of a website. knowing that you can get it everywhere, and you can even get it for your animals. So they did look at, the FDA in their study did look at pet products as well, and tested for the cannabinoids there. So they looked at beverages and capsules and gummies and edibles. So they looked at many different ways that people ingested CBD.
Wow. I mean, that's, the fact that we don't have any evidence is scary. And that's, if we're having these parents, moms especially, seeing this out everywhere. And like you said, it's normalized. They see it and they think, oh, it's on the shelf. It's got to be fine for me to take, right next to any other medications that you would take when you were pregnant, have a headache, whatever. So, and that's why it's really important to have, experts like you on the podcast. So you can enlighten us on things that we didn't even know existed, like Kratom. And, because that's the stuff that we have to know so we can counsel moms. And, we can take really thorough health histories when we're admitting these moms into the unit with their babies to make sure we're not missing anything. And that's, part of nurses is, our job as a nurse is also to keep up to date with, hot topics and stuff that's out there. And, and I really appreciate you sharing all this information and all the work you've had on it, because I think it'll be very useful to NICU nurses when they're dealing with, these moms that are coming in and making sure that we're asking them those tough questions of what else are you taking? What other supplements are you taking? Because they may not think anything of taking CBD or Kratom because it's readily available, right, and there's no information out there for them. They know they can't take certain ththey might not know that they can't take that. So.
Right. So we sometimes have to go down the list. How about Kratom? How about echinacea? How about vaping? Do you vape? How often do you vape? How many milligrams of nicotine in your vape juice? Those kinds of questions are very important for us to ask. 1/4 of the adolescent population is vaping nicotine, and we know, being in the NICU, the babies do definitely withdraw from nicotine as well. And it looks like opioid withdrawal. Yeah. So asking those questions, knowing what's out there, and for us to say, hey, I saw that sign. What on earth is that stuff? Because these are places that I do not usually go in to buy things. So it's a stretch for me. I chicken out and park my car sometimes 3 blocks away. I'm just very chicken. But anyway, I really appreciate the opportunity to really, again, refresh, renew everything that I do. I was very, very lucky to find the new July data yesterday from the Food and Drug Administration, because my husband had picked up one of those free newspapers. And being in Washington State, this one newspaper, there must be 12 pages of all the marijuana stores and CBD and specials they're having. And all. So I was able to pick that up from him and then go do the research. So I greatly appreciate the opportunity to be able to learn more myself.
Thank you so much. We've really learned a whole lot. I know I did, and I know it's going to be very useful in our practice and make us better NICU nurses. So thank you so much for coming and talking with us today.
Great. My pleasure.
Make sure you never miss an episode by subscribing now. This podcast is made possible by listeners like you. Thanks for your support and letting us into your ears. Have a great day.